Hello, future RMTs. Welcome to the discussion about hypothalamic and pituitary function. Our learning outcomes are as follows. Number one is to recall the function, biosynthesis, and metabolism of hypothalamic and pituitary hormones. Number two is to interpret laboratory results to determine abnormalities in hypothalamus and pituitary gland. To start with, let's discuss and define what is a pituitary gland. Pituitary gland came from a Latin word and a Greek word which means pit mucus. Okay? And pituitary gland is referred to be the master gland. Why? Because of its capability to transpond. Okay? Because of its transponder capability, which means our pituitary gland is referred as the master gland because of what? Because of its capability to secrete hormones, no, it secrete hormones, these hormones, as being secreted by the pituitary gland, and these hormones are essential to regulate the other glands in synthesizing another hormones. Okay, that's why our pituitary gland is referred to be the master gland. Okay, pituitary gland or the hormones secreted by our pituitary gland is needed for the metabolism, gonadal, thyroidal, and adrenal function. Okay? What do we mean by metabolism? Let's say, for example, TSH, no? TSH being secreted by our anterior pituitary gland will have a direct effect or meron siyang it will give stimulation or it will stimulate thyroid hormone to be released. And the thyroid hormone, the same thing goes with your growth hormone, is responsible for the metabolism. Okay. We also have the gonadotropins being secreted by the anterior pituitary gland. And the same thing, ganun din ang ginagawa for gonadotropins or gonadal functions. Adrenal function is the ACTH, the overall regulator of our adrenal gland. O tandaan mo, si ACTH, overall regulator of the adrenal gland. Why? Because it is the only hormone that will triggers or that will stimulate adrenal gland to secrete hormones. Okay? Again, it is referred as a transponder because it translates neural inputs, okay, into a hormonal or endocrine products. Now, there are distinguishing features of our pituitary gland. Okay, what are these distinguishing features of pituitary gland? Number one is we have the feedback loop. We have what we call the positive feedback and the negative feedback. Okay, when we said negative feedback, as the hormone is being secreted, it will lessen or it will decrease the release of trophic hormones. On the other hand, positive feedback, it will increase. No? Habang dumadami yung hormones na pinuproduce natin, and tataas din yung pag-release ng trophic hormones because of its activity. Number two is, another distinguishing feature of our pituitary gland is the pulsatile secretion. Pulsatile secretion. Another one is we have the diurnal rhythms. And number four is we have the environment or external modifications. Okay? So these are the distinguishing features of our pituitary gland. Now, there are three distinct parts of our pituitary gland, namely the anterior pituitary gland, the posterior pituitary gland, and the intermediate lobe. Okay? Anterior pituitary gland, being referred as the adenohypophysis, is the one, no, that originates from the rocket's pouch. Posterior pituitary gland, also referred as the neurohypophysis, arises from the diencephalon. Diencephalon. Sorry, ay sumulat. Diencephalon. cephalon. Okay? And intermediate lobe, also known as the pars intermediaris, has a little functional capacity in our body. Now remember, anterior pituitary gland is referred, no, as the true endocrine gland. And it's the largest portion of the hypothalamus of the pituitary gland. Posterior pituitary gland, it is nice to know that posterior pituitary gland is just responsible for storage and release. Okay? Malaga nating tandaan na si posterior pituitary gland is just for storing and releasing hormones. It is not capable of synthesizing hormones. Now take note guys that the pituitary resides in the pocket of the sphenoid and surrounded by dura mater, which is the the part of our spinal column or spinal central nervous system. Now, for the functional aspects of hypothalamic and hypophyseal units, this illustration shows the rational anatomy of pituitary and hypothalamus. Hypothalamus is also important. That's why there is a debate between which is the master gland. Is it the hypothalamus or the pituitary gland? There are some who are claiming that the master gland should be the hypothalamus because of its capability to secrete releasing hormones that will trigger our pituitary gland to release and secrete stimulating hormones. Okay? But because of the capability or ability of our pituitary gland to release stimulating hormones that is important in the metabolism, gonadal, uh, thyroidal, and adrenal function, and being referred as the hormone or the adrenal gland that is capable of secreting these hormones for other hormones to release, then our pituitary gland is referred as the master gland. Okay? But there is still a relationship between our hypothalamus and pituitary gland because our hypothalamus will be the one to detect that there is something need in the body. Okay? Hypothalamus will be the one to detect, okay, there's something wrong in the metabolism or in the homeostasis. We have to release the hormone. It secretes CTRH, it secretes GnRH, so that this pituitary gland will be able to secrete also the hormones. Okay? Remember people that the afferent pathways or inputs to the hypothalamus are integrated in many or various specialized nuclei and processes, okay, in order to resolve into specific pattern responses. Okay? Now, there are characteristics of hypothalamic response pattern. And what are the responses? Number one, similar to each pituitary or specific pituitary hormone. Number two, open loop negative feedback mechanism. Number three, pulsatility. And number four, cyclicity. Okay? I have here an example of a simple feedback loop of our hypothalamus, pituitary, and the target for endocrine gland. Okay? Let's say, for example, this one, hypothalamus will release TRH. Okay? TRH is referred as the thyroid releasing hormone. Okay? Thyroid releasing hormone. Now, what will happen? Okay? What will happen is that this TRH, no, the TRH, the thyroid releasing hormone, will react into our pituitary gland. Okay? Para saan? So that this pituitary gland will be able to produce TSH. TSH to our thyroid gland. So that our thyroid gland will be able to secrete thyroxine. Thyroxine is a thyroid hormone. Now, there's already an activity. There's already the production of thyroxine. This thyroxine will give signal to pituitary and hypothalamus to stop the production of TRH and TSH so that the thyroid gland will not secrete enough or much or more thyroxine hormone or thyroxine. Okay, this is just a simple feedback loop, no, showing a negative feedback, showing a negative feedback mechanism. Bakit? You already have the production of the hormone necessary. Then stop the production of releasing hormone and stimulating hormone. Okay, we will reserve the discussion on how the TRH respond to pituitary and and how the pituitary releases TSH and the TSH reacted to our thyroid gland. Okay, again, this feedback mechanism or this simple feedback loop shows a negative feedback. Okay? What is negative feedback? When we said negative feedback mechanism, it means that if there is already a hormone produced, no, this hormone will uh, decrease. Okay? Will decrease the release of tropic hormones. This one and this one. All right. Now, let's discuss what is posterior pituitary gland. Again, it arises from the encephalon, and it is only capable of what? It is only capable of storage and release. It is not capable of secreting. No? Wala siyang kapangyarihan na mag-secrete ng hormone. Because this oxytocin and vasopressin, also known as our antidiuretic hormone, is not produced by the posterior pituitary gland, but rather produced by our what you call this, hypothalamus, and just store and release it and just store it in our posterior pituitary gland until such time that this ADH and oxytocin is needed by the body. As you can see in this illustration, we have there what we call the paraventricular nuclei and the dendritic secretion from the magnoneurons. This will be the one that is capable of releasing or synthesizing our oxytocin and our vasopressin that will be stored in our posterior pituitary gland. On the other hand, we have there our anterior pituitary gland, which is again the largest portion of our pituitary gland and originates from the Rackett's pouch. It is also referred as the true endocrine gland because of its capability of secreting, synthesizing our hormones. No? And anterior pituitary gland is the one responsible, no, in regulating and release of our hormones such as prolactin, growth hormone, gonadotropins such as FSH and LH, TSH and ACTH. Okay? The hormones being produced by our anterior pituitary gland can be classified as peptides or glycoproteins. We have here the hypophysiotropic and hypothalamic hormones. Again, these hormones are peptides in nature and bioactive amines, which are most common products of the hypothalamus. These are the hormones produced by our hypothalamus in response to the need for the stimulation of in response to the need of releasing our stimulating hormones that is capable for releasing other organs or other hormones rather. Okay? The hypothalamic hormones can be or can have multiple actions. Let's say, for example, thyrotropin releasing hormone, no, the one that is responsible for releasing TSH and prolactin. TRH or thyrotropin releasing hormone is a three amino acid sequence, no, that is responsible for the TSH and prolactin. This is what we are telling that it has a multiple actions, primarily because of the TSH, no, for the release of TSH. And gonadotropin releasing hormone or the GnRH naman is the one responsible for releasing LH and FSH, which are our gonadotropin. Corticotropin releasing hormone is for the one responsible for the release of ACTH. GnRH is for growth hormone. Somatostatin is on the other hand naman inhibits the production of GH and TSH. Okay, that's why it affected no the synthesis of our growth hormone and TSH. Kaya pag mataas yung somatostatin natin sa katawan, there is what we call problem in the synthesis of in the synthesis, yeah, and the metabolism of GH and of our TSH. Dopamine, on the other hand, is the antagonist no, of our prolactin. It inhibits the release of our prolactin. Okay? Take note, guys, that the hypothalamic or the hypophysiotropic hormones are found throughout the central nervous system, gut, pancreas, and other endocrine glands. We have here the amino acid sequence. You might wonder what are the amino acid sequence of each releasing hormones. Okay? Now, when we said anterior pituitary hormones, or when we said anterior pituitary gland, siya ngayon true endocrine gland, no? Ngayon, pag sinabi naman nating anterior pituitary hormones, they are larger and complex than the hypothalamus. And there are two types of anterior pituitary hormones, such as tropic hormones and direct effectors. What do we mean by tropic hormones and direct effectors? Or what is the difference between tropic hormones and direct effectors? Take note, guys, that once we said tropic hormones, no, tropic hormones, ang action nito is the action of tropic hormones are specific for another endocrine gland. Okay? That is specific for other endocrine gland. While for direct effectors, there are directly on the peripheral tissues. Ibig sabihin, let's say for example, growth hormone. Growth hormone will not signal or will not stimulate any other gland or any other endocrine gland. It will have a direct effect. Kaya nga sabi natin sa kanya, direct effectors. Not endocrine growth hormone, an anterior pituitary hormone, is responsible for the feedback of insulin-like factor. Insulin-like factor is increase no sa mga pasyenteng mayroong acromegaly, which is a problem in a growth hormone. Prolactin, on the other hand, is also a direct effector because it has a direct effect no on the peripheral tissue of the breast. While when we said tropic hormones, no, tropic hormones naman are specific for another endocrine gland. That's why if we have a problem in our tropic hormones, there will also be a problem or deficiency in our hormones, in other hormones. Let's say, for example, TSH, the thyroid stimulating hormone, being a tropic hormone, meron tayong deficiency ng TSH because of the problem in the pituitary. Okay? Secondary hypothyroidism. The problem is in the pituitary. The pituitary is not capable of secreting our TSH. Therefore, if our pituitary is not capable of secreting our TSH, our thyroid gland will not be able to secrete our thyroxine and thyrothyroxine, triiodothyroxine. Bakit? Wala mag-stimulate kay thyroid gland eh. This is an example or a classic symptom of what we call secondary hypothyroidism. The problem is the TSH. The problem is within the pituitary gland. Okay, and tertiary hypothyroidism, there is a deficiency in the production of TRH. Si thyrotrophin releasing hormone na yung problema natin. Kaya wala tayong TSH, wala rin tayong thyroxine and triiodothyroxine. So that is the difference between our tropic hormones and direct effectors. Luteinizing hormone directs directs testosterone production from the testes, no, from the Leydig cells of the testes. Our follicle stimulating hormone FSH naman, feedback hormone niya inhibin. Okay? And remember that FSH is responsible for the ovarian recruitment for the folliculogenesis and also for the spermatogenesis. Thyroid stimulating hormone, on the other hand naman, is for thyroid hormones such as your T4 and T3, your thyroxine and your triiodothyroxine. Adrenocorticotrophin releasing hormone or adrenocorticotrophin hormone or ACTH, on the other hand, is the one that regulates the adrenal steroidogenesis or the production of our steroid hormones, and one of which is our correct cortisol. Okay? So these are our anterior pituitary hormones. They are important. Now we also have what we call pituitary tumors. Pituitary tumors is defined as is seen, no, in 20% of a patient. However, this patient has a silent pituitary adenoma. Hindi agad siya na-detect, hindi agad natin nakikita. Findings consistent with pituitary tumors are observed in 10 to 30% of patients undergoing MRI or magnetic resonance imaging. Now, pituitary tumors accounts to 91% of lesions from the patients who undergone transpenoidal surgery. Okay? And aside from that, physiologic enlargement of pituitary can be seen during what we call pregnancy and also what we call puberty. Now the question is, okay, the question is, what do we mean by the word transpenoidal surgery? Okay, this is a condition, surgery, ibig sabihin, there's a removal. Okay, removal of what? Removal of what we call, uh, what you call this? Not of the tumor, no, or of the mass in the pituitary gland. Actually, this is a type of surgery in which merong pinapasok parang endoscopy, no? Pinapasok sa ating nose na nagiging dahilan kung bakit nagkakameron ng lesions. Okay? Nagkakameron ng lesions sa ating pituitary gland. Okay? Again, mayroong pinapasok na parang endoscope, no, to visualize, and at the same time, it is the removal of the tumors, removal of the masses in our pituitary gland. Growth hormone is also known as the somatostatin. I'm sorry, somatotrophin pala rather. I'm sorry for that. Somatotrophin. Okay? This is structurally similar to our prolactin and HPL or human placental lactogen. Okay? It is a direct effector class of our anterior pituitary gland for metabolism, which is stimulated by our growth hormone releasing hormone and inhibited by what we call somatostatin. Now, the production or the peak production of growth hormone can be seen on the onset of the sleep. Take note that our growth hormone, no, is considered as what we call ampibolic. What do we mean by ampibolic? When we said ampibolic, it is a characteristic which influences both anabolic and catabolic processes. Okay? When we said anabolic, that is what we call protein synthesis. No? Protein synthesis in the what? Protein synthesis in our skeletal and other tissues. Now, how about catabolic process? Catabolic process is a type of process, no, naman for the synthesis of carbohydrates. Example, glycolysis. Okay? Take note that catabolic process is our mechanism for digesting food and molecules in the body. Para saan? For the use of energy. So that's why growth hormone, responsible siya sa ating metabolism because of its characteristics of being a ampibolic hormone, which influences both anabolic and catabolic processes. Aside from that, growth hormones allows the transition, no, from fed state to fasting state without shortage of the substrates. Okay? Aside from that, growth hormone, take note of this, people, provides a direct effect on our insulin on glucose metabolism. Ano ibig sabihin nun, sir? It means that it directly antagonizes the effect of insulin. Therefore, ano yung meron? If we have a problem, no, if we have increased growth hormone, mataas din alin? Yung glucose natin. Why? Because it has a antagonistic effect on our insulin. No? Ina-antagonize niya yung effect ng insulin. And as we all know, insulin is our natural hypoglycemic agent. If there is someone who is inhibiting the action or antagonizing the action of our insulin, eh wala tayong mangyayari dyan. Mataas talaga ang glucose natin. Bakit pa? Ano ba ang ginagawa niya? It provides hepatic gluconeogenesis. Yung mga stored fats natin, i-convert natin into glucose. It also stimulates lipolysis. Okay? And it stimulates the production of what we call insulin-like growth factors. I hope you can follow. You can follow. No? Aside from that, growth hormone is responsible for the synthesis of protein. Bakit? Because of its catabolic process. Now, there are conditions that stimulates the growth hormone secretion, and there are conditions that inhibits the growth hormone secretion. What are those? Sleep, exercise, physiologic stress, amino acids such as arginine, hypoglycemia. Right? Eh bakit sir yung hypoglycemia ay nag-i-stimulate ng growth hormone? Paano kang meron pag may hypoglycemia? Mababa ang ating glucose. Oh, eh nag-stimulate tayo ng growth hormone. Para saan? Inhibit natin yung ginagawa ni insulin. Eh kaya tayo nagka-hypoglycemia. Pataasin natin ang glucose level. Steroid hormone or sex steroids such as estradiol. Okay. Alpha agonists such as norepinephrine and beta blockers such as propanolol. No? Ito na, pangalawang beses na ito na-encounter sa propanolol na ulol. Huwag naman mauulol, ha? Now, what are the conditions naman na nag-i-inhibit ng secretion ng ating growth hormone? Glucose loading. Okay? Alpha blockers such as phentolamine, beta blockers such as epinephrine, emotional and physiogenic stress, nutritional deficiency, insulin deficiency, thyroxine deficiency. Okay? So again, take note, it has a direct antagonizes effect of insulin on glucose metabolism. Again, it promotes hepatic gluconeogenesis and stimulates our lipolysis. Now, what are the testing for growth hormone? Based on the dynamic physiologic growth hormone axis. Okay, we have what we call oral glucose loading. This is a definitive test for determining the production of growth hormone. Procedure: the patient will undergo overnight fasting, 8 to 10 hours of fasting. Then the patient will be given glucose load, 100 grams glucose solution. And the measurement will be done from 60 to 120 minutes. The same thing goes as what we are doing in OGTT. Okay. We also have your insulin tolerance test, which is considered as the gold standard and confirmatory test for growth hormone. Arginine stimulation test is considered as the secondary confirmatory test. Now, take note, guys, ha? Take note. Okay. The testing for the autonomous production of growth hormone relies on the normal suppressibility of the growth hormone by glucose loading. Okay? Now, what do we mean by acromegaly? When we said acromegaly, this is a result of physiologic and autonomous growth or overproduction of what we call growth hormones, wherein the patient has more than 50 nanograms per ml of growth hormone. Sorte naman nila, oh, ang tatangkad nila. Okay? What are the causes of acromegaly? Causes of acromegaly is what we call gigantism. We also have what we call bony and soft tissue overgrowth. We also have progressive enlargement of hands, feet, mandible, and even our skull. Okay. Another one is arthritis, diabetes, hypertension. There is no question for diabetes and hypertension, right? Alam na natin kung bakit. Atherosclerosis, bakit? Effect na ng diabetes at saka ng hypertension. Muscle weakness, okay? And shortened life expectancy. Okay? The specimen requirement for testing acromegaly is a fasting serum and a complete bed rest for at least 30 minutes before blood collection. Bakit? Kasi kung stress ka, di ba sabi natin dito, maliwanag siya dito, physiologic stress will stimulate exercise will stimulate. Naglakad-lakad ka bago ka kakunan. So therefore, magpahinga ka muna for at least 30 minutes. Now, if you know the wrestler, the Great Khali, siya yun eh. No? Siya yung matangkad. And as we discussed, gigantism, progressive enlargement of the hands, feet, mandible, and skull, kitang-kita natin yan kay the Great Khali. Ganito yung kamay. No? This is a hand of a normal people. And this is a hand of a person with acromegaly. Okay? Again, sabi natin, no, growth hormone stimulates the production of insulin-like growth factors or growth factor 1, the IGF-1. Therefore, that could be used as the screening test. Bakit? Kung mataas ang ating growth hormone, ibig sabihin, mataas din ang ating insulin growth factors, especially insulin growth factor 1. That's why yun ang ginagamit nating screening test for acromegaly. Therefore, it is increased in the patient with acromegaly and low in GH deficiency. Okay. Now, what are the strategies? Okay. We have strategies to stimulate growth hormone. Number 1, ano po yun? Insulin-induced hypoglycemia. Tingnan natin kung mag-hyperglycemia yung pasyente. However, insulin-induced hypoglycemia is outdated method. Number 2, we have combination of infusions. Combination infusions of what? Of GHRH and amino acid arginine. Bakit, sir? Di ba sabi natin si arginine? Saan na po yan? Okay. Nag-stimulate ng ating growth hormone secretion. Okay. What else? And the last one is the infusion of L-arginine coupled with DOPA. L-DOPA. O bakit? Ano si DOPA? Balikan natin ulit. Ang sabi natin kay DOPA, no? Nasa ba yung DOPA na yan? Ang sabi natin kay DOPA, siya ay merong effect. No? Meron siyang effect sa production ng ating growth hormone. Okay. Now, what is growth hormone deficiency? Kung meron tayong growth hormone na excess, we also have what we call growth hormone deficiency. Growth hormone deficiency is usually occur or seen in both adults and children. Okay? If children, it is primarily because of genetics or tumors. Okay? For adults, result of structural and functional pituitary abnormalities. Now, growth hormones can be what we call a deficiency in growth hormone, sorry. Deficiency in growth hormone can be classified of what we call karyopangiomas, yung nakikita natin sa children because of tumor. Okay? Ito lang yung masakit dito, no? As we age, there is an inevitable consequence of growth hormone production. So habang tumatanda na pala tayo, nababa yung production natin ng growth hormone. Now, as per genetic defects or as per genetic abnormalities, ano yung meron? Let's discuss. Number one, there is what we call loss of the growth hormone gene, the GH gene. Another reason is that there is what we call GH insensitivity. Another reason is because of recessive mutation in GH-RH gene, no? And the failure of the GH secretion. And lastly, we have what we call structural lesions, okay, of pituitary. These are the conditions, no, in relation to genetic defects, in relation to genetic effects that affected our growth hormone production. Moving forward is we have our prolactin. Take note, guys, that prolactin, no, is what you call this, structurally similar to growth hormone and placental lactogens. Dagdagan natin. And placental lactogens or human placental lactogen. Placental lactogen. Okay? This is also a direct effector hormone targeting the breast. Take note that prolactin is also considered as a stress hormone. Okay? Prolactin is also considered as a stress hormone because it has a vital function in reproduction. No, I'm sorry. This is considered as a stress hormone and at the same time has a vital function in the production or reproduction. Considered, para maliwanag, baka malito, considered as stress hormone and at the same time considered as vital in reproduction. Okay? Prolactin, being a direct effector to the breast, no, has the action of initiation and maintaining lactation among women. Take note that prolactin is also considered uh, capable, no, I'm sorry. Prolactin is also considered as capable in the regulation of our tonic inhibition. Okay? Prolactin acts in conjugation with estrogen and progesterone to promote breast tissue development. Now, the major inhibitor of prolactin is dopamine, and the consequence of what we call excess prolactin is what we call hypogonadism. Hypo, mababa, gonads. So the problem in our gonads. Again, take note, excess prolactin usually leads into what we call hypogonadism. We'll reserve the discussion of hypogonadism in sex hormones. Now, what we call prolactinoma? Prolactinoma is a tumor that directly secretes prolactin. Ano ibig sabihin nito? Hindi talaga yung ating anterior pituitary gland ang nagsisecrete ng prolactin. There is a tumor. There is what we call pituitary adenoma that mimics the production or that mimics the action of our that mimics the production of our uh, prolactin. Ha? Hindi po to secret. Directly, okay? Tumor that directly secrete prolactin. Now, prolactinoma represents the most common type of what we call pituitary tumor. Okay? Now, the clinical presentations depends on the patient. Okay? It depends on the patient, the age of the patient, the gender of the patient, and of course, the age, gender, the size of tumor. Now, anong pinagkaiba sa gender? For premenopausal woman, sino ba itong mga premenopausal woman? No? Naapektuhan na alin? Yung tinatawag nilang menstruational irregularity, amenorrhea, absence of that, no? Infertility and galactorrhea. For men, no? Headaches and visual complaints. Now, what are the other cause of what we call hyperprolactinemia? No, in connection to our prolactinoma. Kasi mayroong direct effect o mayroong direct secretion ng prolactin. Tumataas yung prolactin natin. Therefore, we have what we call hyperprolactinemia. Okay? So what are those? Pituitary stalk interaction, dopaminergic antagonist medications, no? Thyroidal failure, renal failure, and polycystic ovarian syndrome or ovary syndrome, PCOS. Now, those are the other conditions that triggers prolactinoma. No, that triggers hyperprolactinemia. Sulat ko nga. Okay? So this is the effect of prolactinoma in women, in premenopausal women, okay? Menstrual irregularities, amenorrhea, infertility, and galactorrhea. For postmenopausal women, pituitary mass, headache, and visual complaints. Actually, headaches and visual complaints is also seen sa mga man. And the direct effect of prolactinoma in man is the reduced libido and erectile dysfunction. Okay? Hyperprolactinemia can be physiologic, this can be pharmacogenic, and that can be pathogenic. Bakit? Like what I've said a while ago, yung causes of hyperprolactinemia, aside from the tumor itself, yung pituitary stalk interruption, that is a physiologic, okay? Or could be considered, that is considered as pathologic. Yung mga dopaminergic antagonist medication is pharmacologic, renal failure physiologic, renal failure physiologic, ano? Uh, thyroidal failure, and the same thing goes with with polycystic ovarian syndrome. Take note that a person with hyperprolactinemia is increased in the prolactin level of greater than 150 nanograms per ml. Okay. Now, if the person naman ay merong 25 to 100 nanograms per ml, it means that there is a moderate elevation seen, no, in pituitary stalk interruption, use of dopaminergic antagonist medication, and primary thyroidal failure, renal failure, and even PCOS. Ito yung mga sinasabi ko sa inyo kanina. These conditions triggers hyperprolactinemia. At kapag ikaw ay may mga gantong condition, if you have this type of condition, no, yung prolactin level mo is between 25 to 100 nanograms per ml. Now, other clinical conditions that can be useful for our hyperprolactinemia evaluation is the TSH and the FT4. Because it eliminates the primary hypothyroidism caused by elevated prolactin. Tingnan natin ang level ng ating TSH and FT4. Okay? We can also perform MRI. Okay? If a tumor is associated or suspected, careful assessment must be done. Okay? And that will be what you call this? That will be assessed with MRI or magnetic resonance imaging. Okay? Now, how are we going to manage prolactinoma? Okay, the management. I will change the color because I think red is not suitable for your eyes. Okay. So what I have here is the management. Yan. Can I make the screen black? Yan. The management of prolactinoma. Number one, therapeutic goals. Goals. So we have the reduce tumor. Okay. Restore normal gonadal function and fertility. Next one is prevent osteoporosis. Okay. And we also have preserve normal pituitary function. Now, what are our therapeutic options? For therapeutic options, it includes a simple observation, surgery, removal of the mass, okay, radiotherapy, what else? Medical management with dopamine. Bakit with dopamine? Ini-inhibit ni dopamine si prolactin. Secretion of prolactin is inhibited by dopamine. Okay? We also have what we call, di na ako magsusulat. We also have what we call idiopathic galactorrhea. Idiopathic galactorrhea. Sir, what is idiopathic galactorrhea? O, mas maganda, tanungin muna natin, ano ibig sabihin ng idiopathic? Kapag sinabi natin idiopathic, there is no known cause. No? Walang maliwanag na dahilan kung bakit merong ganan. Idiopathic galactorrhea is a seen in lactation women, lactation woman with normal prolactin levels. Okay? Idiopathic galactorrhea is seen in a patient, na lactating woman with normal prolactin levels. Wait lang ha. I'm just looking for that. Bakit parang hindi ko ata naidagdag? Wait lang. Okay, ito pa pala. Sige. On the last part, I don't know bakit siya last part siya napunta. So now let's proceed to what we call thyroid stimulating hormone. Okay. Thyroid stimulating hormone is a hormone produced by our anterior pituitary gland. And the main purpose of our TSH is for the production of our thyroid hormones. Okay? The uptake of iodine by the thyroid gland. Iodine is important in the production of our thyroid gland, in the production of our thyroid hormones. No? It increases the number and size of the follicular cells where this thyroid hormones is being synthesized. The blood levels of TSH may contribute into the elevation of infertility. We also have what we call adrenocorticotrophic. Wala po dapat itong H. Okay. Adrenocorticotrophic hormone, ACTH. This is a single peptide without disulfide bonds. And take note, this is responsible for the production of our cortisol. Okay? The regulator. Kaya ang sabi kay ACTH, the overall regulator of adrenal gland. Ngayon, deficiency of ACTH will lead into atrophy of the zona glomerulosa and zona reticularis. O pag-usapan natin yan pagdating natin kay adrenal gland. So example of mechanism of our ACTH ay ganyan, no? The CRH or the CRF. F stands for factor, is important mediator in the stress response, no? To give signal to our pituitary gland to release ACTH that influences the production of steroid hormone secretion that will be secreted by our adrenal gland, one of which is our cortisol. The highest level of ACTH is seen between 8 a.m. to 6 a.m. to 9 a.m. May variation. Kaya dito ka dapat magkuha ng level ng blood for that. Lowest level is 6 to 11. Take note, natatandaan nyo pa ba that if we are going to collect blood sample for ACTH, dapat pre-chilled tubes na ginamit natin, ang gagamitin natin. And the appropriate collection time is between 6 a.m. to 8 a.m. Kasi nandun yung highest elevation. Tingnan natin kung mataas ba talaga. Okay? Yan. Ito yung maganda. Nandito pala, nung daldal ako ng daldal. Ito yung maganda. No? Dapat din nating tandaan that we should not use glass. Bakit? Should not have contact with glass. Bakit? Because it will adhere to the glass surface. And once that ACTH adhere to the glass surface, ano yung mangyayari? Decreased levels. So, sir, ang ginagamit, gumamit tayo ng plastic na red top. Okay? Plastic red top will do. Okay po yun. Ngayon, kailan mataas ang level ng ating ACTH? Kapag meron tayong Addison's disease. What is Addison's disease? Later, pag-usapan natin. Ectopic tumors, and after protein-rich meals. That's why fasting is required kapag mag-ACTH tayo. Kasi, bakit po ang fasting is required kapag mag-ACTH? It is required simply because it is affected by a recent consumption or recent ingestion of what we call food rich in proteins. Okay? So ngayon, ano naman yung tinatawag nating Addison's disease? Addison's disease is a body produces insufficient amounts, no, of hormones produced by the adrenal glands. Okay? Adrenal glands produce too little cortisol and often insufficient leads to aldosterone as well. Kaya nga yung Addison's disease, tinatawag din nating adrenal insufficiency. Ayan. This is an example of a patient or an illustration of a patient with Addison's disease. Okay? Now, how about gonadotropins? Gonadotropins includes the follicle-stimulating hormone, FSH, and the luteinizing hormone. Okay? Which are all important for diagnosing fertility and menstrual cycle disorders among women. Ito mahalaga ha, yung FSH at saka LH parehas siyang makikita sa babae at sa lalaki of all ages. So this is the summary of the action of our FSH and LH among men and female or among male and female. Okay? So ang action ng FSH sa male is spermatogenesis, LH is increased testosterone production. FSH among female is stimulates ovarian follicle, increase estrogen level. LH naman stimulates progesterone level. Okay? Gonadotropins, LH, helps the Leydig cells to produce testosterone in male. Sa babae naman, necessary for ovulation. Okay? LH acts on the cells to cause synthesis of androgens and estrogens. Increased FSH is the diagnosis of premature menopause, and lack of FSH and LH after, or increase of FSH and LH are seen after menopause due to lack of estrogen. Okay? Now, what do we mean by hypopituitarism? Ito, pasensya na, hindi ko alam kung bakit dito siya napalagay sa likod. Hypopituitarism or hypopituitarism is a condition wherein there is a failure of either pituitary gland or even hypothalamus in result to the loss of anterior pituitary function. No, I repeat, hypopituitarism, okay? Hypopituitarism is a condition due to the failure of either our pituitary gland and hypothalamus that affected or that resulted, that's a nice term, resulted, that results in the loss of the function of our anterior pituitary gland. Now, we have what we call panhypopituitarism. When we said panhypopituitarism, there is a complete loss of our pituitary gland and hypothalamus. Okay? Panhypopituitarism, there is a complete loss and function of our complete loss of the function of our pituitary and hypothalamus, which resulted to the loss of the production of our tropic hormones. We also have what we call monotropic hormone deficiency. Monotropic, this is one word lang ha, one word. Monotropic, sige na, baka malito pa ang sambay ng Pilipino. Okay. The monotropic hormone deficiency, ano naman po ito? Loss of a single hormone lang. Loss of a single hormone. At least, di ba? Isang hormone lang yung na-loss. But in panhypopituitarism, complete loss of the function of our pituitary and even hypothalamus yielding to the loss of our tropic hormone synthesis. Okay? Now, what are the causes of hypopituitarism? Pituitary tumors, parapituitary and hypothalamic tumors, trauma, radiation, infarction, infiltrative diseases, immunologic, familial, and idiopathic. Okay? Hypopituitarism can be associated sa mababa, low, or sometimes normal levels of tropic hormones, depending kung ito ba ay hypopituitarism or kung ito ba ay panhypopituitarism or monotropic hormone deficiency lang. Take note also that both of the tropic and target hormones level should be measured. Bakit? Para malaman natin if there is a really failure in the pituitary gland. Ngayon, example natin, yung ating TSH at saka yung ating T4 at T3. Kung mababa ang TSH natin, mababa din ang ating T4 at T3. Therefore, no? Therefore, meron talaga tayong problema sa ating hypothalamus, sa ating pituitary gland. Okay? This is often referred as the secondary deficiency. Now, what we have is oxytocin. Ano naman yung oxytocin? Oxytocin is a posterior pituitary, no. Oxytocin is a hormone. No? Oxytocin is a hormone released by our posterior pituitary gland. Okay? Posterior pituitary gland. Released and stored by our posterior pituitary gland. Ano yung meron kay oxytocin? Oxytocin, no, oxytocin is a cyclic non-peptide with a disulfide bridge connecting amino acid residues 1 and 6. Oxytocin is very similar to the composition of our ADH. Okay? Remember that oxytocin has a crucial or vital role in lactation. The same thing as with prolactin. Okay? Now, there's also what we call a study that suggests that oxytocin stimulates contraction of gravid uterus, and that is what we call the Ferguson reflex or reflex. Bakit? Ang sabi, it has a major role in labor and parturition. Okay. I have a friend who is ang tawag dito, midwife. I don't know if this is really she is doing, pero sabi na talaga to sa akin. Kapag daw nahihirapang maglabas ng bata yung kanyang pasyente, sorry for the word, she placed the areola area of the breast to what you call this, to promote the synthesis or to promote the release of oxytocin. Okay? However, instead of doing that naman, meron naman tayong synthetic oxytocin, and that is the picotin. Picotin. No? Si picotin is used for obstetric to induce labor. Kaya minsan, yung picotin hindi pitocin pala ng picotin. Pitocin hindi po siya OTC or over the counter drug. Bakit? Kung ini-induce po nito ang labor, ibig sabihin, pwede siyang gamitin for absorption, for abortion. Okay? Oxytocin is released in response to the neural stimulation of the receptors in the birth canal, uterus, and touch the receptors in the breast. O kaya na hinahawakan yung may areola area to release oxytocin. No? Stimulates muscle contraction during delivery and lactation. Okay? Now, take note of this. Oxytocin has been shown to have effects on the pituitary, renal, cardiac, and immune functions. On the other hand, we have our antidiuretic hormone, which you are all familiar with, also known as the vasopressin or the arginine vasopressin or AVP. This is a cyclic non-peptide that is structurally similar to oxytocin with a identical disulfide bonds that differs from the two amino acids. Okay? This non-peptide acts on the distal convoluted tubules and our collecting ducts in the kidney for reabsorption. Alam niyo na yun eh, reabsorption of water. Okay? The major action of ADH is to maintain homeostasis ng water. And this hormone is released by neural impulses. Now, aside from that, no, increased blood pressure, okay, decrease in blood volume, or blood pressure will likewise stimulate ADH release. Doon sa raas na paulit-ulit nating sinasabi, dapat natatandaan yun. Okay? It has a potent pressure agent and affects blood clotting factors 7 from the hepatocyte and von Willebrand factor released from the endothelium. ADH, no, yung physiological and emotional stress increase ADH output, possibly in part through emetic stimuli. Now, ano yung mga inhibitors ng ADH release? Ethanol, cortisol, lithium, dicyclocycline. Ano tong mga ito? Mga anti-diuretic, di ba? I'm sorry, ito yung mga diuretics pala. I'm sorry, mga diuretics. Ethanol. Ethanol is also known as the drinking alcohol. Kaya pag nag-iinom ka, ihi ka ng ihi eh. Okay? Now, ano yung diagnostic test natin for ADH and vasopressin? Okay, overnight water deprivation, concentration test. Tingnan natin, yung urine osmolality. If the urine osmolality is greater than 300 milliosmol per kilogram, okay, there's a problem in our ADH. Now, what are the conditions wherein ADH is associated? We have diabetes insipidus. O, alam niyo na din yan, right? Diabetes insipidus. Deficient in ADH resulted in severe polyuria greater than 3.5, 3 liters or 2.5. Diabetes insipidus. Ano yung mga clinical pictures of a patient with diabetes insipidus? Normoglycemia, polyuria with low specific gravity. Okay, alam niyo na kung bakit. May polydipsia and polyphagia. Ano yung polyphagia? Yung excessive hunger. There are two types of diabetes insipidus, the true diabetes insipidus or the neurogenic diabetes insipidus, and we have the nephrogenic diabetes insipidus. So, when we said true diabetic insipidus or neurogenic diabetes insipidus, there is a deficiency of ADH with normal receptor. Okay? True diabetes insipidus, problema natin is ADH deficiency, but we have receptor. Kapag naman nephrogenic, normal ADH but abnormal yung receptor natin. Ibig sabihin, yung receptor ng ating ADH sa kidney ang problema. Na nagiging dahilan kung bakit mataas yung LDH natin, kung bakit nagiging dahilan kung bakit ihi ng ihi. Merong polyuria. Okay? Polydipsia is excessive water intake. Okay? So for the synthesis of this topic, we know that hypothalamus and pituitary gland plays an important role in the metabolism and synthesis of our hormones. Pituitary gland, referred as the master gland, is responsible for secreting stimulating hormones that is responsible for giving signal to other endocrine gland for the release of our hormones. Anterior pituitary gland, part of the anterior pituitary gland is a uh, uh, large portion of the pituitary gland, which is referred as the true endocrine gland because of its capability to synthesize uh, hormones such as our tropic and direct effector hormones. Kapag sinabi nating direct effector, direct to the peripheral tissue. Example of which is the growth hormone and the prolactin. Tropic hormones is specific for other endocrine gland, such as FSH, TSH, and your LH, as well as ACTH. Okay? And posterior pituitary gland is just responsible for the release and storage of ADH, also known as the vasopressin or arginine vasopressin and oxytocin, because these hormones are produced by our hypothalamus rather. Okay? We also have what we call prolactinoma, the problem in the prolactin level. We also have acromegaly in growth hormone. We also have what we call hypopituitarism, which is a condition affecting the loss of tropic hormones because of the function or the loss of the function of our hypothalamus and pituitary gland. The etiology of hypopituitarism includes pituitary, paracellular or metastatic tumors, postpartum ischemic necrosis, lymphocytic hypophytiasis, severe head trauma, no? And radiotherapy. Fungal infections, tuberculosis, and syphilis can also the cause of our hypopituitarism. Now, the treatment for our hypopituitarism includes thyroxine, glucocorticoids, and gender-specific sex steroid. Overall, we said that the function of our hypothalamus and the function of our pituitary gland is essential in maintaining the homeostasis of our body. With that, I hope you were able to learn the function of our hypothalamus as well as the pituitary gland and the importance of our hormones. Do not forget to scan this code and God bless you.